Hello, everyone, and thank you for attending today's webinar, Centralized FeNO Collection and Analysis in Clinical Research, presented by Circassia Pharmaceuticals and ERT. Before we begin, we want to cover a few housekeeping issues. At the bottom of your audience console are multiple application widgets you can use. If you have any questions during the webcast, you can click on the Q&A widget at the bottom and submit your question. We will try to answer these during the webcast, but if a fuller answer is needed, or we run out of time, your question will be answered later via email. We do capture all questions. If you have any technical difficulty, please click on the Help widget. It has a question mark icon and covers common technical issues. An on-demand version of the webcast will be available approximately 1 day after the webcast and can be accessed using the same audience link that was sent to you earlier. Our speakers today are Dr. Kathy Rickert, Vice President, Medical Development, Circassia Pharmaceuticals, and Christian Behini von Lazen, Product Manager, ERT. And with that, I'd like to pass it to Kathy.
Thank you. Good morning or good afternoon to everyone, depending on where you are. Today we're going to spend about the first 40-45 minutes talking a little bit about FeNO, which is the fractional hexyl nitric oxide, and how it may be used, what kind of data you can get from it, and what the attributes of it when you're using it in asthma. Just as a quick reminder, I'm not sure about everybody's backgrounds on the phone, so may go into some things that maybe some of you already know, but just bear with me. So just looking at the pathophysiology of asthma, you can see that primarily inflammation drives all of the different things we see in asthma, including airway hyperresponsiveness, clinical symptoms, and reversible airway obstruction. Now, we can measure these different things in different ways. So airway hyperresponsiveness, we can do PC20s, which is methacholine challenge testing, and other types of challenge tests. We can do bronchodilator response. Of course, the challenge testings come with its own difficulties trying to do that in a clinical or research setting. For reversible airway obstruction, we can measure spirometry. For our symptoms, we generally are using questionnaires. And then for inflammation, it's been very hard to do things in the past because other than using invasive methods, we haven't had anything easy to use. And that's why we're going to be focusing on FeNO today. Keep in mind, asthma is a very heterogeneous disorder. It's a complex. It has multiple phenotypes. This is largely attributed to interactions among many of the genes and between these genes and the environment. Increasingly, we recognize this as a syndrome rather than a specific disease. And it's very variable in its underlying inflammation, clinical symptoms, its natural history, and response to treatment among the patients who suffer from this disease. The variability often contributes to the suboptimal diagnosis and therapeutic control that one may see. Going along with those heterogeneity, you can see there are many different asthma phenotypes. Though Th2 inflammation is the predominant inflammation we see in asthma, and that may also be referred to as allergic or eosinophilic inflammation, there are other phenotypes in asthma that may not be related to Th2 inflammation. And you can see this here on this slide. So the Th2 phenotypes are on the left-hand side, and the non-Th2 are on the right-hand side. Talking about tools to measure inflammation in asthma, it goes from the invasive to non-invasive. In general, in years past, the only way we could really measure inflammation was invasive. That's either doing a bronchoscopy, a bronchial wash, we call a bronchoalveolar lavage or a biopsy. Again, these are very difficult to do, particularly in a study situation, also in a clinical situation. So generally not done. You can do sputum investigations and sputum eosinophils. Again, difficult to do because of standardization. You need the right personnel who knows how to do the procedure, who can count the procedure. You have to standardize everything very, very clearly. You can also do total IgE or blood eosinophils, but they may not be the best correlates with some of the asthma measures you may be measuring. And then we have the new one called FeNO. So how does FeNO help? So nitric oxide is an endogenous regulatory molecule. You all have it. You all make it in your body. It's regulated by a family of enzymes called the NO synthesis. The one we see in asthma and in the lung is generally the inducible NOS-derived NO, which is predominantly produced in the bronchial wall epithelial cells. And it increases during Th2 inflammation. If you look on the cartoon on the right-hand side, you can see in the general normal healthy population, it is generally regulated by IFN, interferon, which is a corticosteroid-resistant mechanism. However, on the bottom, you see in asthma, it's regulated by the Th2 system, the IL-4s, IL-13s, mast cells, eosinophils. And that's a very corticosteroid-sensitive mechanism. So what's the rationale for FeNO testing in the management of respiratory disease, and how would you look at that when you proceed to putting that into a study? So significant correlations are observed between FeNO and eosinophilic or Th2 airway inflammation. The Th2 or eosinophilic airway inflammation also corresponds to steroid response. This would also respond to other types of responses to other anti-inflammatories, such as a biologic therapy. And FeNO and the bronchial hyperresponsiveness in steroid-naive patients with mild asthma also correlates together. So it can be used as a replacement for looking at bronchial hyperresponsiveness. How does one measure FeNO? Well, this is the picture of the Niox Vero, which is the newest version of the machine to measure FeNO on the market. You can see it measures FeNO from 5 to 300 parts per billion in exhaled air. 5 is the minimum measurement with the Niox. 300 is the maximum measurement with Niox. There are cut points at 25, which indicate low Th2 or ICS responsive inflammation. This is for adults. It would be 20 in children. The cut point for high Th2 inflammation is 50 in adults and 35 in children. When you're thinking about using a FeNO, what additional factors may you need to take in mind when you're measuring FeNO? Well, there's some factors that can affect your FeNO levels, but we should be clear that these are generally not clinically significant. So, for example, if you look on the top of the yellow line, airway infection, this is particularly viral infection and particularly rhinovirus. So somebody who has a cold from rhinovirus may see an increase in their exhaled nitric oxide. Certainly allergic conditions with allergic rhinitis and atopy can increase your FeNO level. A nitrate-rich diet, this would include foods that are high in nitrates. However, it's often very difficult to eat enough to significantly raise your FeNO level. And acute bronchodilator. Now let me explain the bronchodilator a little bit more for a minute, because this is actually a normal and a naturally something that you'd expect to see. So if somebody is very obstructed and you're measuring exhaled air and you're measuring FeNO in that exhaled air, if you're obstructive, you might not be getting out the true level of NO, which means that in order to get a more accurate vision, you'd give them a bronchodilator, open up that airway, and so now when you read a FeNO level, it would be more accurate. So in a clinical practice, when you're practicing, if you have somebody who's very obstructive, you might actually want to give them a bronchodilator before measuring their FeNO level. Now let's look at the items below the line. So spirometric maneuvers that that can cause bronchospasm may cause a decrease in your FeNO level, although some studies have shown that you see very little difference when you're measuring spirometry. But of course, if you have a patient who's particularly sensitive and they develop bronchospasm, that can cause a lower FeNO level. Smoking may decrease your FeNO level. You see different effects in acute smoking versus somebody who has a chronic smoking condition such as COPD. Certainly, inhaled corticosteroid therapy will decrease your FeNO level, but that's, again, an expected therapeutic effect. You give inhaled steroids to treat the disease, you would expect to see your FeNO level go down, as that's one of the things you may be measuring. And then as we talked about the acute bronchodilator, the acute bronchoconstriction, so anything that causes bronchoconstriction that narrows your airway will limit and lower the amount of NO you can get into your breath. Again, how would you change that? You would do a bronchodilator before you did the FeNO level in somebody who's acutely bronchoconstricted. Alcohol consumption and exercise can also lower your FeNO levels. I'm just going to pause for a quick minute to just review a couple of concepts, because as we go through studies, you need to keep this in mind, and this is kind of the UG part of it, because you have to remember what these things mean. So just briefly talk about sensitivity, specificity, and predictive values. Remember, this is a diagnostic test, and when you do a diagnostic testing, you're oftentimes talking about the sensitivity and the specificity of the test when you're doing the test, unlike when you're looking at or measuring an effect on a drug. So sensitivity is the ability of a test to correctly classify an individual as diseased. So that means the probability of a test being positive when they truly have the disease. Specificity is the ability of a test to correctly classify an individual as disease-free. So the probability of a test being negative when the disease is not there, is when the disease is absent. Positive predictive value, the percent of patients with a positive test who actually have the disease. And negative predictive value, the percent of patients with a negative test who do not have the disease. So again, I always keep that little cheat sheet with me when I'm looking at studies that are analyzing results from a diagnostic test. So let's look at some of the data. So first, this is a study by Zedekowski, who looked at patients who had established asthma. And here you're looking at the fact that in patients who have allergic asthma, non-allergic asthma, or in healthy volunteers, that FeNO levels were significantly increased in both asthma groups, but much higher in patients who have allergic or that Th2 phenotype of asthma versus patients with non-allergic asthma. So clearly can pick up those patients who have a Th2 phenotype. It also can distinguish asthma from other allergic conditions. So if you're looking at patients who may have asthma, but they also may have allergic rhinitis alone, non-allergic rhinitis, eczema, or urticaria, and you oftentimes may see these things in your practice or in the studies that you're looking at, that patients who have asthma are going to run much higher levels of FeNO if they have that Th2-driven allergic type of asthma. In this study, you can see the FeNO was 27 parts per billion, was considered the optimal cut point for an asthma diagnosis, and the positive predictive value was 86%, and the negative predictive value was 87%. Let's take a look at some other types of tests you might do in both your studies or in clinical practice to support an asthma diagnosis. So this is looking at a group of patients who was examined using both spirometry methods, sputum eosinophils, and FeNO. You can see we're going to now characterize these different tests by sensitivity, specificity, positive and negative predictive value. You can see first, if you look at the first 4 lines, which are talking about the spirometric maneuvers, the sensitivities of these tests are really low. And why is that? Because A lot of patients who have asthma will have normal spirometry. And remember, sensitivity means is that the probability of the test being negative when or having a negative result when the patient actually has the disease. So since many of the patients will have normal spirometry, the sensitivity is going to be very low. However, the specificity of these are very high because those who don't have asthma will generally not have abnormal pulmonary function tests. And that correlates very well with the positive predictive value of 100%. But again, you can see the negative predictive value is somewhat low, again because of the fact that spirometry may not pick up those people who have asthma because it will be normal in many patients. Now let's look at other ones you can use, the sputum eosinophils at greater than 3% and FeNO at greater than 20 parts per billion. You can see their sensitivity and specificity are very similar to each other, so they have pretty good, robust both sensitivity and specificity for both eosinophils and FeNO. And their positive and negative predictive values, again, are in a pretty good, robust area to be used, particularly from a negative predictive value. But the positive predictive value is not bad, and pretty much the sputum eosinophils and FeNO are close to each other. Now, this study used a fairly low level of FeNO, so 20 parts per billion, to support an asthma diagnosis. In general, we would use a higher FeNO level, and if you do use a higher FeNO level, for example, that's suggested in the ATS guidelines, your sensitivity and specificity would increase along with your positive and negative predictive values. So the advantage of using FeNO here compared to these other techniques is that FeNO provides the advantage of both being non-invasive and very easy to perform. It correlates very nicely with sputum eosinophils. Another thing that FeNO can do is predict who's likely to respond to inhaled corticosteroids. Now, oftentimes, it's both a clinical question, but also a question that we see in research, is that you want to predict who's going to respond to your treatment, whether that's a anti-inflammatory, for example, a steroid, or whether it's another anti-inflammatory, such as a biologic. FeNO could help identify those patients who are going to respond. In this study, they looked at FeNO, but they also looked at FEV1, bronchodilator response, and they also looked at things such as methicillin challenge, bronchodilator responsiveness. Here you can see they have graphed both the FeNO and the FEV1 bronchodilator response. And if you look at the sensitivity and specificity, the FeNO had much higher sensitivity and specificity than FEV1 than predicting who's going to respond to steroid therapy. It is also better, which are not plotted here, versus methicillin challenge and bronchodilator response. Another way that you can use FeNO is to look at a dose-response curve. So oftentimes we're trying to predict what is the dose response of a particular medication and how quickly might we see a response to a particular anti-inflammatory medication, whether that be a steroid or otherwise. We can see here that we're looking at a study now that looked at both FeNO and airway hyperresponsiveness, which was done with an AMP challenge, in a dose response of an inhaled corticosteroid in patients who had mild asthma. This study was performed 3 days after treatment. This was using an ultra-fine beclomethasone steroid dose. You can see here on the left-hand side the FeNO and on the right-hand side the AMP PC20 challenge. You can see that after only 3 days of a low dose versus a high dose, you can start to see a dose response being shown here with a quick response in FeNO after only 3 days. You can also see the same thing on the AMP challenge side, whereas after 3 days, the low dose, high dose, an improvement in your AMP challenge, again indicating a dose response. Certainly, FeNO, in this situation, it's much easier to do versus doing the AMP challenge. So it's something that you might be able to do and substitute versus using another type of technique in your clinical trial or also in a clinical practice. When we look at FeNO, FeNO helps indicate who's going to respond to inhaled steroids in patients with both non-eosinophilic or eosinophilic asthma. Now, as you know, for years past, it's been often difficult to actually phenotype our patients. We didn't have a good way of phenotyping them based on inflammation because the techniques to use that were very difficult to do. You'd have to do a bronchial biopsy, you might have to do sputum eosinophils, and so forth, and they were not always readily available or easy to do. And that makes a big difference when you're either trying to decide what treatment to use on patients or trying to decide what type of patients you may want to bring into your study so that you will see a response to a particular medication. Here you can see we're looking at two different types of patients. Those who have non-eosinophilic, so these would be your non-Th2 type of asthma patients, versus your eosinophilic or your Th2 type phenotype. And they're looking at the response of these two types of patients to an inhaled corticosteroid. We're looking at both the mean methacholine challenge test, which are the top graphs in both sides, or the mean FeNO, which are the bottom graphs in both sides. Now, first, if we just turn to the non-eosinophilic area here, you can see if these patients receive placebo or methimazole, 400 micrograms per day, you can see that in methacholine challenge, there is really little change in this person in their methacholine response. You see the same thing with FeNO. So if you go to the bottom part on this side, again, in these patients, if they receive placebo or if they're receiving a steroid, you see very little change in that FeNO number. Now, if you go to on the right-hand side in those patients who have eosinophilic or your Th2 type of phenotypic asthma, you see a very different pattern here. So once they're receiving a treatment or a placebo, you can see those patients who receive placebo actually get worse. Their methacholine challenge gets worse. And why is that? Well, because you're not treating their underlying inflammation. However, if they're treated appropriately with inhaled steroids, you can see that their methacholine challenge gets better. Likewise, on the FeNO, you can see again here, if they're treated with placebo, these patients' FeNOs increase, meaning their inflammation is getting worse. However, if you're treating them with an inhaled steroid, you can see that their FeNO improves because now they're receiving that appropriate anti-inflammatory therapy they need to treat their disease. So again, you can see how, first of all, FeNO could be used to first phenotype your patient, so who's going to respond to an inhaled steroid, and then used to follow that patient when you're using a particular treatment, either both clinically or in a study, on what kind of response you're seeing. And then certainly it's much better, much easier to use than doing methacholine challenge in a large study. One other area that FeNO may help you with is predict relapse of asthma upon inhaled corticosteroid withdrawal. So in this study here, patients were withdrawn from steroids and their FeNO was followed, so we can assess the sensitivity and specificity and find a particular level of FeNO which predicts a future exacerbation and a future relapse. You can see here, based on this study, that a FeNO level of 49, which was at 4 weeks after steroid withdrawal, was highly indicative of an asthma relapse, with a sensitivity of 71% and specificity of 93%. Again, you may think about how this might be used in a particular study if you're worried about if you're looking at a dose response or if you're looking at some kind of withdrawal of certain medications. You can use FeNO either in both a safety indicator that the patients may be getting worse, or also in an efficacy indicator to show stability of the disease. So now I'm going to turn to FeNO and asthma outcomes. This is very important data. There's a fair amount of it. I'm going to go pretty quick through this. This may be not something that you're going to readily be able to use all the time in your studies. Certainly it's very relevant in a clinical perspective, but there may be some situations of studies that you may do that you may want to consider how FeNO may fit into that mix. When we're talking about asthma outcomes, we're particularly looking at asthma exacerbations. And we're looking at a method of how FeNO can be used to help manage the patient to give them the appropriate amount of inhaled corticosteroids when they need it and not when they don't need it, so you can look at a reduction in exacerbations. This is the first early study done by Smith that looked at patients over a year period of time. They were first stabilized, and then they used FeNO versus just a guideline-based approach alone in the control group to manage your inhaled corticosteroid dose. And you can see here that the FeNO monitoring versus conventional management for inhaled corticosteroid dose, and actually this is the actual colors in here are actually reversed on this slide. I didn't realize this, but the FeNO should be the green, and the control group is the purple. And there are a lower amount of exacerbations when patients were managed by FeNO when not. Now, this was not statistically different, even though it was a 46% reduction, because of the fact that they originally predicted that they wanted to see a 60% reduction in exacerbations. If we look at the steroid dose, however, you can see the FeNO group throughout the period of time, that year-long period of time, used less inhaled steroids than the control group alone. So they're able to manage with lower exacerbations with a lower inhaled corticosteroid dose. Another study originally done by Powell and published in The Lancet. This is a study where they looked at 220 pregnant women with asthma, and people always say to me, well, these are pregnant women. As you all probably realize, we treat pregnant women with asthma with the same medications that we treat other individuals with asthma. And so this is very relevant. It's also very relevant to a pregnant population because you really want to keep their asthma under control and use the least amount of medication you can to keep them under control. Patients are randomized to either symptom-based therapy, which is based on guidelines, or FeNO-directed therapy. And the primary outcome was the total number of asthma exacerbations for which the patient sought medical attention. And they looked at a couple of other outcomes, endpoints that you're all used to using: quality of life, asthma treatment, and then fetal outcomes. This is the main study results here. You can see on the left-hand side is the number of exacerbations. The right-hand side was the daily inhaled corticosteroid dose. You can see the control group is in the very light purple, and the FeNO group is in the dark purple. And first, if you look on that left-hand side of the asthma exacerbations, you can see throughout the treatment period, there were a much lower number of exacerbations in the FeNO group than in the control group. And if you look at underneath that graph, 25% of the females in the FeNO group had an exacerbation versus 41% of patients in the control group. Now, if you look at the right-hand side, you can see that compared to the control group, the FeNO group was managed with a lower daily dose of inhaled corticosteroids. So despite the fact they were using less medications, they had better control with much fewer exacerbations. The number needed to treat here was 6, so for every 6 patients receiving treatment, 1 was presented for having an exacerbation. This is an important number that many of you are probably familiar with from a managed market association. They want to see how this relates to the number needed to treat. And another important outcome was for neonatal hospitalizations were significantly reduced in the FeNO group, which was 8%, versus the control group, which was 17%. Just to give you an idea of the number to need, because sometimes this is a number that you're not familiar with if you're not used to using it. If you look at some other types of medications and interventions and their number needed to treat, so if you look at atorvastatin, which is a statin used to treat and prevent cardiovascular events, particularly MI, The number needed to treat for that is 99. For flu vaccination, meaning that you want to prevent flu, the number needed to treat for that is 23. And then you can see from FeNO in this study, the number needed to treat was 6. So a very low, good, robust number. Now let's turn to a slightly different study, as this study was done, again, looking at asthma exacerbations as an endpoint, but done in entirely a primary care population. So this was a randomized controlled 52-week clinical trial, included adults with atopic asthma who were already on inhaled corticosteroid treatment. They're randomized to either usual care, as in the guidelines, or FeNO-directed therapy as directed in the algorithms. And you can see the usual endpoints: quality of life, exacerbations, inhaled corticosteroid use, and lung function were looked at. Just gives you a schematic of the study design, showing, and something that most of you are very used to looking at, that they had a run-in period, they had the control group versus the FeNO group, and the various visits where they measured both FeNO, and then other visits they measured FeNO along with quality of life and spirometry. The population was basically recruited from 17 primary cares in Sweden. You can see how the baseline characteristics show that they were generally well controlled and had mild to moderate asthma. Their FeNOs were in the low 20s, and their FEV1 predicteds were about 83 to 84%. They were on a budesonide equivalent of about 400 micrograms per day. And you can see here, this is the comparison of the cumulative incidence of exacerbations. The FeNO-guided, you can see, is in the green, the control in the purple. You can see throughout the time period of observation that the control group had a 28.4% exacerbations versus the FeNO group, which had 16.1%, and that was a statistically significant difference. There were no differences seen in lung function or mean daily use of SABA or mean daily use of inhaled corticosteroids. But despite the fact that this patient group came in fairly well controlled on inhaled steroids, you can still see a robust reduction in exacerbations. I'm just going to turn quickly for a minute to some of the pediatric data. Most of that data we just talked about was adults. It can also be used in pediatric studies and in pediatric evaluations. Piersman did a similar randomized 52-week clinical trial of 101 children. Again, they were a very similar design, either using GINA guidelines or FeNO-directed therapy. Similar outcomes: symptom-free days, asthma exacerbations. In this study, they did have a high amount of missing data for primary outcomes, so they actually analyzed all their secondary outcomes for primary intent. Here you can see the outcomes here, and if you look on basically the right-hand side of the p-values, you can pick up the fact that the number of exacerbations over 1 year was significantly different, with 35 occurring in the clinical group and 18 in the FeNO group. Unscheduled asthma visits or contacts over the year was also statistically different, with being higher in the clinical group, 28 in the clinical group, and 14 in the FeNO group, also statistically different. You can see statistical difference are also shown in patients children who had greater than 1 exacerbation or greater than 1 unscheduled visit for this population. So there were significantly fewer exacerbations and unscheduled contacts were observed in the FeNO group. And fewer participants in the FeNO group experienced 1 or more exacerbations. And they actually concluded in this study that not implementing FeNO use was associated with a significantly increased risk of experiencing exacerbations. Now, they also looked at what's called the discordance concurrence ratio, and a type of study design here they were looking at, since you used 2 different algorithms. You looked at the algorithm of the patient, and you also compared what might have happened if they were on the other algorithm. And you looked at a difference. So if the same outcome would occur, no matter what algorithm they were on, then it was not likely that the particular treatment had much of an effect. But here, after calculating 74% of all the decision points, they saw that the DC ratio was 1.05, meaning that more than 50% of the decisions were impacted by FeNO. So they made a different decision when FeNO was used, which ultimately led to those outcomes of reduced exacerbations. The last area I just wanted to reach on here was a study by Petsky, which basically also did a similar study looking at children greater than 4 years of age. They were again randomized to either FeNO therapy or usual care if they were taking anti-inflammatory therapy. They were seen every 4 months. They took into account atopy in this study, which was interesting, and that only meant that they let their FeNO levels run a little higher if they had a particular atopic history. And the primary endpoint was children with an exacerbation. You can see here that there was, again, a much lower amount of children who had exacerbations in the FeNO group versus a control group. As we talked about in the parallel study, the number needed to treat here was 4. And though this was not particularly powered on exacerbations, you can see that the exacerbation rates were lower in the FeNO versus the control group. So the conclusions from her study were that significantly less children had 1 or more exacerbations. The number needed to treat was 4. So the rate of exacerbations did not reach statistical significance due to a lack of power. And the asthma quality of life FEV1 diary scores were similar between the groups. One other study was performed looking at cost effectiveness by Han Koop in the Netherlands. They did a similar study where they controlled patients in 3 different groups of partial asthma control, which meant they allowed patients to carry more symptoms, a tight asthma control where they tightly controlled their asthma symptoms, or a FeNO-assisted asthma control. And this was primarily done for economic endpoints. So they wanted to look at the cost and the use of medication. And here it showed that the FeNO-assisted asthma control had a greater than 86% chance of reducing cost effectiveness. It reduced asthma medication use and improves asthma control, while providing similar areas of quality of life, days with asthma-related limitations, adherence to medications. So if you look at the chart here, it just looks at the exacerbations here. And again, the FeNO-assisted, again, showed less exacerbations overall and the rates compared to the other types of control. Just putting that all together, there's a recent Cochrane analysis done that analyzed all of these studies looking at exacerbations in both an adult and pediatric population. These were those both published in 2016. And you can see in both in the adult and pediatric that the odds ratio of 0.6 in the adult, 0.63 in the pediatrics showed that by using FeNO in managing patients with asthma, you saw roughly a 40% decrease in asthma exacerbations. So how can FeNO be used with asthma outcomes? Well, using FeNO, you can use FeNO comparing management of FeNO versus other types of therapy based on the guidelines to show differences. You can see also that if you look at the data, no study to date has demonstrated that FeNO is inferior to a guideline-based approach. So it has very robust effects. And it's demonstrated that with FeNO, you can see reduction in exacerbations, reduction in prednisone burst, reduction in dose of inhaled corticosteroids, and reduction of cost. So you can see different ways that you might utilize this in using it in different types of studies when you're looking at anti-inflammatory therapy. So let's quickly go, what else can FeNO do? FeNO could particularly be helpful in detecting inhaled corticosteroid non-adherence. This also could be further drawn out to other types of anti-inflammatory therapy. If patients are using FeNO, you can see here you're comparing the use of a budesonide 200 twice a day versus reduction in FeNO, and that the FeNO rose and fell based on inhaled corticosteroid dose rose and fell. So if the patients were more compliant, their FeNOs were lower. There was a positive correlation between adherence and reduction in the FeNO levels. You can also see that the lung function test did not differentiate between those being treated versus not treated with inhaled steroids. So FeNO can be used in a way to look at whether your patients or your subjects are being particularly adherent to a medication in a particular study. And a similar line just basically shows the same thing from another study, is that with good adherence, you can see that the FeNO levels run low, versus the FEV1, which really did not vary whether the patients were adherent or not to their particular medication. I know many of you are probably working in the area of biologics, which is new and exciting, and they're bringing out lots of new medications for this. And FeNO may help predict who will respond to your biologic therapies. I'm going to show you one study from Hanania, which was basically used as a post-hoc analysis to look at treatment effects of Zolar, basically. It was a 48-week study of 850 patients. Patients were divided into low and high biomarker groups. They basically looked at FeNO, they looked at blood eosinophils, and they looked at serum periostin at baseline. And they correlated that with the primary outcome, which was exacerbation rate in each of those biomarker groups. If you look here, the main graph from the study shows you the percent reduction in protocol-defined asthma exacerbations. And you can see we're looking at 3 different biomarkers again. The FeNO was the far left-hand side. You have the eosinophils, blood eosinophils in the middle, and periostin. And if you look at the ability to predict response, that the FeNO group showed the best ability to predict response in reduction of exacerbations. You can see a 53% reduction in exacerbations when those subjects had a greater than 19.5 parts per billion FeNO. You can see the other 2 also predicted reductions in exacerbation, but wasn't quite as good as the FeNO levels. That was for both for eosinophils and for periostin. So you can see here that FeNO can help predict a particular outcome that you might see in a particular trial. If you want to show a reduction in exacerbations, it will help you to use FeNO to bring in patients who have a particular level that are going to show the best response to a particular biologic. All right, just quickly how you interpret FeNO levels. Where here you can see the FeNO levels come in low, intermediate, and high. The low level is less than 25 in adults, less than 20 in children. This generally means that your Th2 type or eosinophilic inflammation is not likely, and these patients are unlikely to respond to a particular inhaled corticosteroid or other types of anti-inflammatory therapy. So if you're designing a particular study looking at top of these compounds, you probably do not want a lot of people who have low FeNOs in that study because you're not likely to show a good response. Your intermediate level is 25 to 50 in adults, 20 to 35 in children. This, again, indicates that this is a cautious interpretation. They do have some elevation in FeNO. It may not indicate that whether they have strong Th2 inflammation or not. And you might consider using inhaled corticosteroids or other therapy in this type of patient. And then you have your high FeNO levels, greater than 50 in adults and greater than 35 in children. Again, this indicates that eosinophilic or your Th2 type phenotype is very likely, and these patients are the ones that are going to show benefit from a trial of inhaled corticosteroids or of other types of anti-inflammatory therapy. In a similar vein, if you're looking at interpretation of people who already have an asthma diagnosis, who may already be treated, you can use your FeNO levels in a similar way. If you look at your low FeNOs, if they come in and they're symptomatic, and the FeNO levels is low, what that means is they're less likely to respond to an increased inhaled corticosteroid dose. You might want to consider something else, a comorbid condition or an alternative diagnosis. If they're not symptomatic and their FeNO is low, it means they have good dosing, and you might consider reducing the dose of the therapy. In the intermediate level, you may want to explore that they're actually, if they're symptomatic, that they're actually taking the medication and they're compliant and know how to use the device. If they're not symptomatic, they still indicate that they may have some underlying inflammation, and you may not want to reduce somebody's therapy in this area. And then those patients who come in and have high FeNO levels, if they're symptomatic, again, you would have to address whether they're actually being adherent to the therapy, investigate whether they actually know how to use the device well, or are they actually using the device properly. And you might consider increasing their dose of inhaled corticosteroid and also investigate their allergen exposure. If they're not symptomatic, you still need to address the fact that they continue to have underlying uncontrolled airway inflammation, and I would not at this time withdraw or reduce inhaled corticosteroids, but you may consider adding another type of medication at times to these patients. So for interpretation, we use cut points rather than reference values. You count for age for children who are less than 12. You need to take the clinical context in which the FeNO is done. When monitoring patients, if you use it for monitoring, greater than 20% change for levels greater than 50 is a significant increase in your FeNO. Greater than 10 parts per billion for less than 50 parts per billion is a significant increase. If you're looking at a decrease of greater than 20% in an elevated FeNO level, often occurs 2 to 6 weeks after anti-inflammatory therapy, and this would support that they were having a response to therapy. So it's one way you can look at whether a patient or a subject in a study is responding to a particular therapy. We're running a little short on time, so I'm going to just quickly talk about how the ATS guideline goes to, talks about FeNO, and then I'm going to just wrap up and turn over to Kristen quickly. So ATS has issued a guideline for FeNO use. It says it offers advantages for patient care, including detecting allergic airway inflammation, determining the likelihood of inhaled corticosteroid response, monitoring airway inflammation to determine potential need for anti-inflammatory, or unmasking non-adherence. And I'm going to just pass through some of these so I can sum up for you before I can turn on to Christian. So what I just want to summarize for you, so if you're looking at FeNO, whether you're using it in a clinical trial or you're using it clinically, how best to use it? Well, you can use it in different ways. So first of all, if you're designing a clinical trial, you can use it to detect the Th2 inflammation or the Th2 type phenotypic patient, particularly if you want to enrich your patients in the trial who are going to likely have a response to an anti-inflammatory treatment. So certainly if you want to demonstrate efficacy of a particular compound, whether that's an inhaled steroid or an anti-inflammatory biologic, you want to make sure those patients can respond to that medication. So this is one way that you can use it when you're designing a clinical trial. You can also use it for monitoring ongoing inflammation. So as your trial is continuing, using at different points to show that you're actually getting an effect and how fast you may see that effect. It has the potential to be used for dose response. So if you're comparing it to another medication or you're comparing it, you're just looking for how fast you see a dose effect and also differences in different dosage. You can use it in that way. And you can also use it in an aid to adherence if you want to particularly detect what your adherence is to your medication in a particular trial. So I'm going to turn over to Christian. we'll still have a few minutes at the end to talk about questions, and I'll be happy to take it at that time. So, Christian, it's all yours.
Thank you, Kathy. So besides looking at the medical perspective and the scientific perspective, also looking at how can we centralize the FeNO collection and analyze the data. So what can be solutions for that? We have a system called Masterscope, which you can see here on the picture, which is a laptop and usually coming as a spirometer. Probably over 15 years ago, it was born as a spirometer in the healthcare market, and we have built that to use within clinical trials. And while using it in clinical trials within the many, many years, it became more a platform to collect multiple data points. So you can collect the spirometry, ECG, ECOA data, and also the FeNO data. And what is the benefit and the high value of doing that? So doing this on a system where you collect multiple data points, we can build in one workflow according to protocol needs to really see when does a FeNO needs to be performed, to control that it's really exactly at that time point when it's supposed to be. And we can have high values of checking that the site staff ensures that the patient has abstained from certain things before they do the FeNO that can have an impact on the FeNO measurement. Also, it is very beneficial that you have the patient on one system assigned to the protocol and then gets all data collected in one centralized database. How are we doing this? So we really guide the user through it with workflows, with pictures. We instruct them what they need to do before they start off with a FeNO value. Also looking at the maneuver itself, we also mimic the maneuver directly on the screen of the Masterscope and not just purely on the Niox Vero device, so that the patient can look at the screen on the Vero and the site staff can look on the Masterscope screen to see if the best quality of data will be generated and guide the patients through the maneuver. When they have done this, it's all according to ATS criteria, so we allow them to do 8 maneuvers for a test if necessary. We immediately calculate mean values of the FeNO. We show error codes so that the site staff is in real time informed about the quality of the data. And in addition, also a very high value is that we can run inclusion and exclusion checks also on the FeNO data compared with the spirometry data, ECG data. So every data needed to make decisions if a patient can be included or needs to be excluded from a trial is in one database, one system, and can be combined. So looking at this, to maximize the accuracy of the data, we look at level 1, which is always the device. So the device has certain mechanism workflows and is developed according to standards. So when the data gets created, that we already can rule out to collect bad data to get the best out of it at the site. Combined with a second level where there are specific site trainings so that we ensure they understand the procedures and get the highest data out of it. And then we have the back end where we have the centralization where we can monitor the data carefully and look at them in real time to make decisions what needs to be done to retrain sites, or maybe there is a problem with the drug to act very early to see that the efficacy can be proven. Okay, that was my short part, and with this, I open this up for questions.
Great. Thank you so much, Dr. Rickard and Christian, for that informative presentation. I see that we do have a few questions, and for our audience members, you can click on the Q&A widget at the bottom of your screen to submit questions as well. The first question is for Cassie. How was allergic asthma and non-allergic asthma differentiated in the Zykowski and/or Corderio papers?
So the allergic asthma versus non-allergic asthma would have been differentiated by the amount of sputum eosinophils they had in their sputum at the time.
Great, thanks. Another question for you, Kathy. What was the variability of FeNO in the Berry et al. Study?
Which study was that?
Berry et al. And you covered a lot of studies, so we can always follow up with folks after the webinar if that one's not immediately jumping to mind.
Right. I'm trying to figure out which one that particularly was. So let's move on to the next one. I'll try to figure out which study that was. Oh, I see
No
which
problem.
one it is.
We can follow up.
So it's actually the one looking at per response to inhaled steroids and non-eosinophilic asthma. And the question was, what was the variability of FeNO?
Yeah.
I don't know that I have it off the top of my head. I'm not quite sure what you're referring to as far as variability in this study for that. But FeNO was used as it's usually used, and certainly in patients who do not have a Th2 phenotype would not show a big response in reduction in FeNO when they're treated with inhaled corticosteroids. So the study is not surprising that they show that the FeNO does not decrease in somebody who does not have a Th2 phenotype versus one who does have a Th2 phenotype.
Great, thank you. One more question for you, Kathy. What is the cost of a FeNO assessment, one FeNO assessment?
I don't know as a clinical person that I actually know all that data. I don't know if Christian can answer that.
Yeah, it's approximately $12.
Great, thank you. Another question here. This one's for you, Christian. We used the NIAX Vero in one of our studies. A question came up from an investigative site if the number of measurements on the NIAX sensor will be reduced when an error occurred during the FeNO test.
Yeah, so if a test was not successful, then it will not reduce the sensor amount of tests.
Great.
So,
I think we have time.
Yeah, so just if I just clarify that, so if you're using the Vero to run a FeNO and a patient or subject doesn't do it correctly and you don't get a actual FeNO value, you do not lose a test off the sensor.
Right.
Great, thanks, Kathy. And we have one last question. This one is for you, Christian. Does ERT provide an overread service for the NIAX measurements?
No, there is no overread service for FeNO measurements. It's because it's not like the spirometry, like a forced maneuver. The outcome is purely the value. So we do not provide here an overread service on this.
Yeah, and I'll just make a comment because the accuracy and precision is very high with the FeNO. And there is no other, as Christian said, it's the number. As you use the number to interpret it, there doesn't appear to need an overread service for that.
Great. Well, thanks again to our presenters for today's informative webinar. This webinar will be posted for on-demand access in the next 24 hours. And you can always email events@ert.com to request a copy of the presentation deck or for any additional questions and answers. Stay tuned to ERT.com for upcoming webinars on safety and efficacy, as well as trial oversight, site optimization, and patient engagement topics. This concludes our webinar, and we hope that you have a great day.